everyone. Thanks so much for joining me for this presentation. And I am Dr. Chandra Mickles, and I'm an associate professor at Nova Southeastern University College of Optometry in Florida. There, I am the director of the Dry Eye Care Center. In addition to that role, I am heavily involved in teaching students about contact lenses and in storing and enhancing my patients' vision with contact lenses. I'm extremely and passionate about spreading the word on all that contact lenses and dry eye management can do. And as such, I've been heavily involved in lecturing and publishing on this topic. So now that you know a little bit about me, let's get started. Well, 2 years ago, a 60-year-old Sjogren's syndrome patient came to me coping with severe dry eye. I mean, she had a hat on. She had sunglasses on due to her severe photophobia. Yes, there was this hurt and this burn that she was experiencing that prevented her from living her life fully. But let me let her share with you her experience.
That before I got my scleral lenses, my life was horribly affected by the dry eye. I didn't go places. I was in constant pain. I had lots of issues that you just don't normally think that would happen, but the dry eye prevented me from living my life fully. With these scleral lenses, it's a miracle. I feel like I've got my personality back, my life back. It is a miracle.
So yes, it was the scleral lenses that gave her life back, man. And she went from using artificial tears every hour to barely needing them at all. And as you see to the right, it not only improved her dry eye symptoms, but also significantly improved her dry eye signs. So yes, scleral lenses are for sure therapeutic, transformative, and can be life-changing for these dry eye patients. But in order for you to have success with your dry eye patients, just like I have in mine, we definitely have to stay up to date on scleral lenses and dry eye. But as you know, what we know about scleral lenses and dry eye is changing at a rapid pace. I feel like almost every 3 months, there is something new on this topic. But fortunately today, I am here to share with you what is the latest in scleral lens success for dry eye disease. I'm going to share with you the latest in insertion solutions, lens surface and reservoir debris management, and application and removal strategies. And finally, towards the end, I'm going to share with you some things that you may want to consider to enhance your success with these patients. But before we dive into this discussion, what are the benefits of scleral lenses? Well, we know this. We know that scleral lenses are beneficial, but the challenges with artificial tears, traditional installation of artificial tears, is that there's limited contact with the ocular surface. In fact, there was a study done looking at the application of artificial tears, and from many of the participants in that study, the artificial tear did not go where it's supposed to go. It landed on their eyelid or their cheek. But with scleral lenses, as you know, we fill the bowl of those lenses with non-preserved saline or non-preserved artificial tears that creates this long-lasting, moist environment that can nurture the ocular surface throughout the day. And there have been many studies that have shown that these scleral lenses are effective in improving the dry eye symptoms and signs that for sure has correlated well with my patients. So we know that these scleral lenses definitely work for dry eye patients, but what insertion solutions should we use for these patients? I mean, it's been great. Now we have so many options for insertion solutions. In fact, now we have some FDA approved options for solutions to fill the bowl of the scleral lenses. One is the scleral fill, and we got Lacapure, a recently FDA-approved option is the Pearl lens, and the most really great recent addition for a unit dose vial option is the new Neutrophil. So we have all these options, but I want you to take a moment and think to yourself, if you had a patient like mine that presented to you, which insertion solution would you use? And would the insertion solution that you use really matter? Well, the insertion solution may matter. If you think about it, for the normal tears, the pH is around neutral, around 7. But for our dry eye patients' tears, they are more alkaline. So the key factor in making the difference in choosing your insertion solution is that some of these insertion solutions may be acidic. And since they're acidic and the dry eye patient's tears are more alkaline, this may exacerbate the dry eye patient's symptoms or dry eye symptoms. So a couple of years ago, there were some researchers that looked into this. They said, well, what are the pHs of these various insertion solutions? And they tested them out. And as you look here at the various insertion solutions, many of them, particularly the unbuffered ones, had an acidic pH. The only unit dose vial saline solution at that time, a couple of years ago, that had a pH in the range of ocular comfort was the buffered sclerophyll.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
So this in mind, I said to myself, well, is there a difference in using a buffered saline in comparison to using an unbuffered saline, like the commonly used Adipac that is used in the United States? So I partnered with a couple of my friends, Dr. Jennifer Harthan and Dr. Melissa Barnett, to do a multi-center trial to investigate this. And so we did the study in moderate to severe dry eye patients or subjects, and they were randomly chosen to use the Adipac for a month and then cross over to use the buffered sclerophyll for a month. And throughout the study, they used the same lenses. So what did we find? Well, we found that the participants had significantly less dry eye symptoms using the Ocular Surface Disease Index questionnaire, and they had significantly improved lens comfort with the CLDEQ-8 questionnaire for contact lens comfort, and they had significantly less corneal staining. We didn't see a difference with the conjunctival staining, and here's the why. The lenses that the subjects were wearing didn't completely cover the ocular surface. And then there was another group who presented this data at the same time we did. We presented it at the Global Specialty Lens Conference in 2019, and a group from Pacific University presented it at the same conference. So great minds think alike, right? And they compared the unbuffered Adipac to the buffered sclerophyll, and what they found was that their sclerophyll had improved dry eye symptoms with the DEQ questionnaire. 5 out of 6 of the subjects preferred the sclerophyll over the Adipac, the unbuffered saline, and they had better end-of-the-day comfort, 4 out of 6 of them using the sclerophyll, and significantly better Schirmer's testing. What they did not find different than us is that they did not find a difference in ocular surface staining. But remember, as you see here, they had an N of 6. But either way, it was apparent to me at that time that all drops are not created equally. And clearly, a couple of years ago, it appeared that using the sclerophyll, a buffer saline, or using non-preserved artificial tears would be the best option for our dry eye patient. But then in 2020, another excellent saline option came along, and similar to sclerophyll, it was buffered. Similar to sclerophyll, it had a physiological pH around 7. So great, two great things. But what sets it apart from the sclerofill or other buffered salines is that this neutrophil contains 5 essential electrolytes to mimic the human tears. And these key electrolytes can support a healthy ocular surface. So the thought came to mind, of course, is this neutrophil, does it improve dry eye symptoms? Does it improve lens comfort? So some researchers set out to do that. And they had participants use the neutrophil for a week and did a comparison to their habitual saline. And what they found, there was reduced grittiness, reduced dryness, significant reduction in dry eye symptoms using the OSDI in comparison to their habitual saline. There was also a case series done in keratoconic patients who had dry eye symptoms, and all 3 of those keratoconic patients had a marked reduction in their OSDI scores, and 1 out of 3 even reported subjective improvement in comfort. So what does this mean? I think today it means that, if you have a patient in your chair, like my patient with severe dry eye, and you're doing all that you can to have success with the scleral lenses, I would highly recommend using a buffered saline, either the sclerofill or the neutrophil. Now, which one is better? Only time will tell. But, you see that the neutrophil has these essential electrolytes that will help maintain an ocular surface. So perhaps that may be the better one. But I can't wait to see more studies and more comparisons on this topic. So, right, I have 2 great options of, insertion solutions to recommend for my patient. But how do I deal with this issue that many of our dry eye patients have with scleral lenses, and that is lens surface and reservoir debris, or lens surface issues and reservoir debris? So my patient, I'm gonna call her Miss Mary because that's my mother's name. And, she did well with the scleral lenses. As she said, the scleral lenses gave her life back. But as months came along, she said, Dr. Mickles, I'm starting to have this blurry vision. And when I start thinking of this blurry, foggy vision, what comes to mind is poor surface wettability or reservoir debris. So what do we do with poor lens wettability? But now we have an excellent, really novel, permanently bonded polyethylene glycol surface treating called Tangible HydraPeg. And this Tangible HydraPeg has been shown to improve lens wettability, right? Tear film breakup time, deposit resistance, lens comfort, and vision, which is fantastic. But we started using it with our dry eye patients, but no one really investigated this in a study to see if does using this coating on scleral lenses for patients with dry eye improve dry eye symptoms, dry eye signs, wiper epididyopathy, lens comfort. So I said, why don't I do a study like that? So again, I partnered with my friends, Dr. Jennifer Harthon and Melissa Barnett, and we did a multi-center study, randomized double mask crossover trial looking at this. So we had participants with moderate to severe dry eye, randomly chosen to wear the untreated scleral lenses for a month and then cross over to wearing the HydraPeg treated lenses for a month. And throughout the study, they used sclerofill as their insertion solution, and they used the Clear Care as their disinfection solution. And what did we find? Well, we found a significant improvement in dry eye symptoms, dry eye signs, lens comfort. We even saw an improvement with wiper epididyopathy, comfortable lens wearing time, which is very important for our patients. and there was a reduction in frequency of foggy vision, which is, her main concern, my patient's main concern. But the important thing, what was rewarding for me, that this was the first research to support, a first publication in a journal to support the HydraPEG use in dry eye patients. So that's what I did. I recommended the HydraPEG for her, and she did have excellent success. However, you want to make sure you remind your patients of these do's and don'ts for ensuring success. And one is ensure that they use the proper solutions. And tangible science that makes tangible HydraPEG has now offers a tangible clean or a daily cleaning and disinfection solution. They also just launched this year is Tangible Boost, which is a monthly conditioning solution that will help ensure the longevity of that coating. But your patients don't have to use Tangible HydraPEG, Tangible Clean solution to clean and disinfect their lenses with Tangible HydraPEG. They can use other solutions, but you want to be sure to use the right solutions to not cause damage to that coating. And the right solutions would be Clear Care, Unique pH, or hydrogen peroxide, and Boston Sim Plus. What you don't want them to do is to rinse the lenses in tap water or store the lenses dry. Now, as I said, my patient did have success with the Tangible HydraPEG. However, there's certain things you want to keep in mind. And I know that you know this, but I want to remind you, in order to have great success, there's certain things you also want to keep in mind. And one thing would be, let's say you have, poor wettability in office. One way to solve that problem, because the lenses are dry, is to do the squeegee technique. And that's what I did yesterday. I had an issue with lens wettability in the diagnostic lenses. And I, took my plunger, put a little conditioner on it, and did a little squeegee of that surface of the lens, just like you would squeegee the window on the car. Another option would be to have your patients go ahead and take a cotton tip applicator, put conditioner on it, and scrub the surface of the lens. I kind of worry about patients doing this at home, so that's why it's so important to be proactive and recommend the HydraPEG in the first place. The other thing I want to remind you of is what can happen with, some blurred vision with lenses is that there's an issue with lens deposits on the surface. And of course, you want to make sure your patients manage their MGD, like, Demodex or as well. And so my patient, in addition to her Sjogren's syndrome and aqueous deficient dry eye, she had MGD. And I had to really be proactive and say, you need to do your warm compresses and lid hygiene. And then also educate them on plunger hygiene and case hygiene, and remembering that they should or recommend for them oil-free makeups and soaps. So she did well with that. My patient did great with that. But then what happened, she said, Dr. Mickles, yes, I don't have this fluctuating vision, but halfway through the day, I start experiencing this blurred vision. So what came to mind then was reservoir debris. And while we don't really completely understand the origin of this reservoir debris, there has been some prevailing theories, definitely some prevailing theories. And one is this is very common in dry eye patients or ocular surface disease patients. And because these individuals have a lot of lipids, and it's been found that individuals with midday fog, that we call it, has significantly elevated levels of lipid. But there are some new theories out there. And one is that tear film has leukocytes, primarily neutrophils. And why? Either due to a mild inflammatory response, but more likely due to hypoxia. What's been found is that in a hypoxic environment, when we're sleeping, there is this influx of these neutrophils. And similarly with scleral lenses, due to the thick reservoirs and thick lenses, tear reservoirs and thick lenses, there is this influx of these leukocytes. The final prevailing theory is the sloughing of the corneal epithelial cells, and it appears to be with this imbalance or electrolyte imbalance with the salines that we use, right? Then there's this increased sloughing of the corneal epithelial cells. And some of you are sitting there, like, okay, Great, we know the theories, but how do we clear this fog? How do we help our patients with that? Well, what we were doing, and I think some of you are still doing, is some of these things that when the reservoir debris happens, we try to manage it. And one thing that my patient was doing, and that's her again there, is the flushing technique. She would take the Addy pack or saline vial and place it on the side of the lens and flush out that reservoir debris. Of course, she wouldn't use fluorescein. I use fluorescein just to highlight what is exactly happening. My patient did like this because it was better than the option of, as you see to the right, removing the lenses halfway through the day and refilling with fresh solution. This, is really the inconvenience for our patients to do this, right? Imagine having to bring all your supplies to work, stop in the middle of the day, find a bathroom, and reapply these lenses. You definitely want to be mindful, if you do recommend this for your patients, to tell them to not do it frequently. The more they do it, it appears causes more reservoir debris due to the disruption of the ocular surface.
Whether you're helping your patients with the daily irritation of dry eyes or combating other ocular surface diseases, Boston Sight Scleral has the data-backed science and experience to help them see the world through a whole new lens.
The other thing that some of us do and have done in the past is use a more viscous agent to fill the bowl of the lens. So this should be able to prevent any debris from getting underneath in the first place, in theory. And then also, of course, manage the MGD so you don't get that debris underneath there. But for me, I'm all about prevention. Prevention of reservoir debris is definitely better than trying to manage it after the fact. So let's take a look at some of these theories to see, possible ways to prevent the reservoir debris from developing in the first place. And one way, if you look at the theory of the sloughing of the corneal epithelial cells due to this electrolyte imbalance in the tear film due to the salines that we use. So, neutrophil contains these electrolytes that mimic the natural tears, so in theory should create a more electrolyte balance, and as such may decrease the sloughing of the epithelial cells and prevent reservoir debris from developing in the first place. So let's see here if there was a study looking at that, and there was a study recently published looking at this. And what they did is they used neutrophil for some participants, and they compared it to their habitual saline. And what they found was that there was less lens fog for 30% of the eyes in the study, significant reduction in blurry or fluctuating vision, and really the greatest outcome to me is the need to remove and refill their lenses was less frequent. So excellent outcome, great promising outcome. Now let's look at that theory of the leukocytes. Remember the leukocytes and the neutrophils due to hypoxia. Is there a way to leverage that to prevent reservoir debris or cause a reduction in the reservoir debris? Well done study at UAB, or University of Alabama at Birmingham, Andrew Pucker and Jason Nichols. And what they found was that whereas a greater corneal clearance had greater odds of reservoir debris. In fact, every 50 microns increase in corneal clearance or central clearance, there was 2 times higher odds of post-lens fogging. So if you look at that OCT image of my patient's scleral lenses, her at the clearance of 400 microns, you see all that reservoir debris between the back surface of the lens and the cornea. When I reduce that clearance, now you see the 200 microns, you barely see any debris there at all. So minimizing that corneal clearance works. And thus far, 200 microns of central clearance may be that ideal point for preventing reservoir debris. Now, for a long time, we thought that tear inflow was a major factor in causing the reservoir debris. 2 recent studies have looked at that, and it appears that tear inflow may not be a factor in the midday fog. So the key to success in dry eye patients with scleral lenses and preventing reservoir debris would be to use a saline that has that excellent electrolyte balance, and of course minimize that lens clearance. Those are the two keys to success. Now let's talk about application and removal strategies. Patients with dry eye often have rheumatoid arthritis, or they're more mature and have some dexterity issues that would inhibit them from applying and removing the scleral lenses properly. So there are a couple of devices that have been developed to derail dexterity issues. And one, simply, you can take a DMV inserter and fit it into the tube as you see there. And this will allow the patient to utilize their hands more for retracting the lids instead of worrying about using their hands to retract the lids and hold the plunger. Really difficult to do, right? Another option is to use the easy lens applicator, the ring applicator. That is also a good option, economical option, in fact. And then we have some newer devices that not only allow the hands to be free to focus on lid retraction, but they also are available and have a LED light, so the patient has some sort of target to focus on. I've used many of these options and they work really well. Now, what's cutting edge? What should we look forward to enhancing success of scleral lenses in dry eye patients? Well, there has been some look at, augmenting success with dry eye drug delivery. In fact, there has been some publications on using, anti-VEGF to, improve corneal neovascularization, also using topical antibiotics in the bowl of the scleral lenses to manage persistent epithelial defects. And even though it is off-label, definitely doctors out there are applying, the immunomodulating agents or prescription dry medications like cyclosporin and lifitegrast to the bowl of these lenses. And thus far, I've been hearing great outcomes when using that or adding like one drop to the bowl of those dry eye prescriptions medications. So I think now you know some of the latest in how to have scleral lens success in dry eye patients, whether it be insertion solutions, lens surface and reservoir debris management, or application and removal strategies. But I know one thing, when it comes to this area, change is coming. Yes, it is. And in order for you to have success when any challenges arise, is to stay in front of it and stay on top of it, so that not only in 2021, but for years to come, you will have scleral lens success in dry eye disease. Thanks so much for your time. On the screen there, you can see my email. If you have any questions, feel free to reach out to me. Thank you.